This is my disclosure slide. So I'm going to kick off with some general background. So birth defects are structural or functional anomalies that occur in utero. A fetus or infant may have a single defect, or there may be multiple defects present, and these may have no minor or major clinical significance. Birth defects can be identified prenatally, for example, through ultrasound, but most are identified at birth. But it's important to remember that some may not be detected until later in childhood or even in adulthood in some cases. So major birth defects occur in around 3% of newborns and are a leading cause of infant mortality, linked to around 3 million deaths annually worldwide. A third of children with defects will die before the age of 5, and a further third will have substantial disability. And of all global under 5 deaths, 1 in 10 are due to birth defects. So as we have already heard from Lynn with respect to neural tube defects, birth defects may be caused by multiple factors and via different mechanisms: genetics, nutritional, environmental, medications, physical conditions, and maternal characteristics such as age. But it's important to note that a substantial proportion of birth defects cannot be linked to a specific cause, as you can see from these figures here. And it's estimated that less than 1% of all birth defects are caused by prescribed drugs. So most birth defects originate in the embryonic phase of the first trimester of pregnancy, and depending on the time at which a specific organ is developing, then you may have a malformation in that organ. There may be defects emerging also in the fetal period. Examples of this might include microcephaly or congenital cataracts. So I've listed some mechanisms of major structural birth defects associated with medicines on this slide, but in this presentation I'm not going to be talking about mechanisms. So in terms of medicines as potential teratogens, susceptibility depends on a number of factors. This may include genetics, dose of the medicine, and other concurrent exposures. The developmental stage at the time of drug exposure is the most important determinant of teratogenic potential, as you can see from the figure on this slide. And therefore, assessment of temporal association between the medicine exposure and the specific defect is critical. Did the exposure start before or during the development of that organ or body part? This talk is focused on preconception ART, so drugs are being taken during embryogenesis. So I wanted to say a word on periconception exposure. So this is the time preceding, including, and immediately following conception. The APR uses the definition of any exposure 2 weeks before conception through to 28 days after conception. And the reason for the focus on this period is that it's the critical window for major teratogenicity. And the Dolutegravir and neural tube defect signal has extended the period of concern with respect to ARVs into the first trimester, because the neural tube closes by 28 days post-conception, and because pregnant women may start or switch ARVs in the periconception period without knowing that they're pregnant. So this slide shows Shepard's criteria for proof of teratogenicity in humans. And I first came across this framework with respect to Zika virus and birth defects. So Shepard came up with 2 main methods, or highlighted 2 main methods for identifying human teratogens. The first is the rare defect, rare exposure method, aka the astute clinician approach. So this is where a distinctive pattern of abnormalities is seen associated with a rare pregnancy exposure. And examples include congenital rubella and fetal alcohol syndrome. And then the other method is via epidemiological approaches, where you also look for consistent findings in high-quality epidemiological studies. And examples of this include folic acid deficiency and neural tube defects and fetal valproate syndrome. So these criteria are not written in stone, but they can be quite a useful tool in terms of understanding and discussing whether or not a medicine is a teratogen. So moving on now to our population and exposure of interest, around 12 million women are on ART, around 65% of those eligible. And I know I don't need to speak about the benefits of ART in pregnancy to this audience. With a pharmacovigilance hat on, it's important to recognise that the exposed fetus benefits in this scenario, so it's not the innocent bystander effect that you sometimes see with other medicines in pregnancy. And globally, around 1.12 million pregnant women are receiving ARVs. And an increasing proportion of them are conceiving on ART. So this slide here shows the percentage of pregnant women conceiving on ART, and I had to dig around quite a lot to kind of come up with these percentages from published cohort and surveillance studies, and they're already out of date. With respect to Botswana, as Rebecca said by her poster yesterday, in the most recent time period, 70% of HIV-positive women who are pregnant are conceiving on ARVs. So in 2017, of the 11.8 million women on ART, 1 in 8 were pregnant. Of the 1.4 million pregnant women living with HIV, 80% were on ART. And if we turn to high burden settings such as South Africa, where 1 in 3 pregnant women have HIV, then around 10 to 12% of all pregnant women conceived on ART. So this really underscores the public health importance of understanding about the safety of periconception exposure to these drugs. So what antiretroviral drugs are women conceiving on? Well, this is highly setting dependent, of course. So in LMICs, this is largely based on WHO guidelines, whereas in resource-rich settings, more drugs are available, we have individualized care, and the patterns really reflect prescribing patterns in the general population living with HIV. I wanted to show you this sort of snapshot analysis of trends in ARV use in pregnancy from the UK. The unit of analysis here is each individual agent. And in this time period, 2005 to 2016, there were over 54,000 individual ARVs prescribed and nearly 40 different drug combinations. Along the bottom of the slide, I've given the percentage of pregnant women on ART at conception. But the main reason for showing this slide, and I know it's difficult to read, but really is to highlight the increasing use of newer drugs and more diverse regimens in pregnancy, including from conception. Because we have limited safety data on ARVs in human pregnancy by the time of drug approval. In terms of the preclinical reproductive toxicity studies in animals, we need to be very careful in extrapolating data from these, because an absence of risk in the animal models doesn't preclude an absence of risk in humans. As we well know, pregnant women are usually excluded from pre-licensure studies of new drugs. And as Angela Kolbers and colleagues recently showed in their paper, there's an average 6-year lag between FDA approval of an ARV drug and publication of pregnancy PK data, including transplacental transfer. We therefore rely on post-marketing studies for data on outcomes. And clinicians and women find themselves with this difficult balancing act. On the one hand, accepting potential risks of these new ARVs despite absence of safety data, or denying pregnant women access to new drugs which may be better than the older drugs where there's more knowledge of safety. But it's important to note that clinical trials are not able to address the question of teratogenicity because insufficient numbers of women are included. So how do we assess periconception ARVs and birth defects? Well, it's important that the exposure to the ARVs is ascertained before the outcome is known. And that doesn't just mean birth, it also means the identification of a defect, for example, through an ultrasound, in order to avoid bias. We need data on the baseline risk in the same population in order to determine the additional risk associated with the drug exposure. But unfortunately, baseline data on birth defects is quite scarce in many LMICs. If our evaluation is restricted to stillbirths, then we're going to underestimate the birth prevalence of defects. This is because risk is considerably higher in stillbirths. So, for example, in the UK, we found birth defects in 16% of stillbirths compared to 3% of live-born infants. Whilst in the Kampala birth defect surveillance program, where 10% of women are HIV positive, the prevalence of major structural external defects was 2.7% in stillbirths compared to just under 1% in live births. And it's also, as I've mentioned already, important to assess whether a specific defect or pattern of defects is observed. So the questions we need to ask are, is the birth prevalence of a defect higher in pregnancies with periconception exposure to the drug in question than in those with periconception exposure to other drugs? And is this also the case in HIV-negative controls? So a word on rare defects, such as neural tube defects, and we've heard a lot about this already this morning. But 2,000 exposures will be needed in the first trimester, will be needed to rule out a threefold increase in birth prevalence for neural tube defects or similarly rare outcomes. So where can we turn to for data on birth defects and periconception ART? I've given some examples here. In terms of population-based birth defect surveillance, we've heard this morning about the SEPAMO study from Rebecca, which is a really excellent example of the utility of these sorts of studies. I'll come on to talk about spontaneous reporting, pharmacovigilance reporting later. In terms of post-marketing studies, these include the pregnancy exposure registries, such as the APR. So a word on administrative health data. These tend to be based in resource-rich settings and therefore are relatively inefficient, as you can see from the Quebec pregnancy cohort example I've given here, because of low HIV prevalence, and therefore you're going to pick up very small numbers of exposures. So this audience knows quite a lot about the Dolutegravir safety signal, and I'm not going to talk at length in this, but just to quickly go through really the course of events. So there were no concerns from animal studies or from the 2017 observational data on outcomes from various sources with respect to periconception exposure, but of course numbers were really small at that time. Then in May 2018, there was the signal from the SEPAMO study, the subsequent drug safety alerts, the WHO guidelines with the note of caution for women of childbearing potential, and plans for global rollout of Dolutegravir were impacted, limiting the use of the drug in women of childbearing potential. At this time, the community raised concerns on their lack of involvement in decision-making with respect to treatment access, as raised in the Kigali communique. So the safety signal really highlighted challenges, A, in communicating uncertainty, and also in having adequate pregnancy pharmacovigilance surveillance globally. And global efforts ensued to identify robust data on periconception Dolutegravir exposure and birth outcomes from other settings and populations, including Botswana, the extension of studies, Uganda, Malawi, and Brazil. The International AIDS Society established a forum on Dolutegravir safety with a multi-stakeholder group, which had 2 meetings last year. And 2 outputs from this forum were an FAQ document, which tried to help provide context and to support policymakers in terms of balancing current safety concerns against known benefits. and a white paper on lessons learned and how to try to minimize confusion when a safety signal is identified. So that white paper was published in the last week or so, and I just wanted to pick out the proposed principles for assessing new safety signals for drugs in pregnancy that came out of that. So they are that the quality, interpretability, and comparability of additional data, including the settings in which the data are collected, is critical, that examination of risk-benefit trade-offs is needed in a range of contexts and settings, and that the potential risk, both magnitude and severity, needs to be weighed up in relation to all potential drug benefits and risks. And that messaging of drug risks and benefits in pregnant women and women of childbearing age needs to be appropriate and needs to involve the affected community. So with respect to risk-benefit modelling, the WHO convened the Dolutegravir risk-benefit modelling working group following the signal. And this group is building on work by two groups using computer simulation modelling, the CPAC group and the HIV synthesis group, both of which have published this year with respect to their models, using the SAPAMO data on neural tube defect risk. So subsequent joint work has been to model the population-level risks and benefits of Dolutegravir use to inform the 2019 WHO guidelines. And I'd like to thank the working group for allowing me to share this summary slide, which is unpublished data. On the top, it's got data from CPAC, and on the bottom from HIV synthesis. And both these models have shown that the use of efavirenz for women of childbearing potential starting ART rather than Dolutegravir in order to avoid neural tube defects and neonatal deaths would likely lead to other substantial negative impacts on a population level, so deaths among women, sexual transmissions, and vertical transmissions. So moving on to passive pharmacovigilance systems, which I mentioned before. And of course, this was the first place that people looked following the Dolutegravir signal. And this work done by Andy Hill and colleagues, where they analysed data from open access pharmacovigilance databases, as you can see the list here, really demonstrated that these databases are inadequate for pregnancy pharmacovigilance. The exercise revealed no clear denominators for exposures. There were duplicate cases, as you can see from the figure on this slide. Around 40 neural tube defect reports after deduplication and additional analysis turned out to be relating to just one case. And most critically, they missed data on the timing of ARV exposure. So I have presented on this slide recent data from the global north, for the most part, on Dolutegravir use in pregnancy. So the bars here represent the total numbers of women on Dolutegravir in pregnancy, with the blue section being those on it pre or periconceptually. So there have been around 500 periconception exposures across the board, but there may be some duplicates because of reporting to the APR. And 42 to 72% of these women started Dolutegravir before pregnancy. So on this slide, I've put the birth defect prevalence stratified according to the timing of Dolutegravir start. So you can see that amongst the periconception group, the birth defect prevalence ranges from 3 to 5%. But all studies are underpowered to detect increased risk of rare birth defects. And I just wanted to add the SAPAMO study numbers to this slide, really just to show how they dwarf the studies from the global north, to highlight the point that these studies need to be conducted in settings where most women with HIV are living and taking these drugs. So moving on to the antiretroviral pregnancy registry, this was set up in order to investigate whether there are any teratogenic risks associated with antiretrovirals in pregnancy. The figure here shows prospective cases with first trimester exposure. The red and the blue lines show the comparator registries and studies that the APR uses to compare birth defect rates in the general population. And you can see that for overall birth defects with first trimester exposure, the prevalence is 2.75. And Lynn is going to talk more later on in this session, so I'll move on. So following the Dolutegravir signal, there was questions raised about whether this could be a class effect. And therefore, there's been a bit of a flurry of studies in the last year looking at other integrase inhibitors. So this table summarizes those studies for Dolutegravir and Raltegravir. So the total numbers exposed in pregnancy are shown here, and then the birth prevalence of defects amongst those with periconception exposure. But it's important to note that these are very small samples, and therefore the prevalence estimates are unstable, and that there's a high probability of type 2 errors. But if we tot all of these numbers up, we see that there are less than 300 to 500 periconception exposures to Dolutegravir and less than 700 to 800 with Raltegravir-based regimens, the range being because there may be duplicate cases. So, with respect to newer antiretroviral drugs, in high-burden settings, we know that well-designed studies, such as the SEPAMO study, can identify signals of potential teratogenic risk with periconception ART for major external structural defects. But these studies are limited to those drugs recommended by WHO or national guidelines, and few such studies exist. Meanwhile, in low-burden settings, where the newest drugs are available and where we have fewer barriers to accurate pregnancy dating, we have good capacity to ascertain birth defects, safety data for specific drugs is very slow to accumulate. And I've tried to show this here in this inverted pyramid. So we have small numbers conceiving on any specific new ARV drug, but of those women, only a minority will have prospective data captured in appropriate studies. So this isn't the first time that we have had a signal with respect to periconception ARV use and neural tube defects. And I've given a kind of potted history of the Adherence story here on this slide. And in terms of the current evidence base on periconception use of Adherence, EPIC, a European cohort collaboration, published earlier this year and provided some data on periconception use of Adherence on around 1,000 outcomes. And so I've totted up all of the total outcomes with periconception use from SEPAMO, from the WHO, the last WHO meta-analysis in EPIC. So you can see 4 neural tube defects in nearly 9,000 exposures. So a causative association has now been ruled out sometime after the initial signal. So just a word on pooled analyses and whether or not we can and should do these. Well, obviously they have been done before, whether aggregate meta-analyses or individual patient data meta-analyses, but there are challenges in doing this. The main one being the heterogeneous data. We have varying data quality and availability from different populations at different time periods. Ascertainment of birth defects differs by study and setting, and there may be varying birth defect definitions and classifications being used. Some studies include, some don't have data on stillbirths. But I think it's important to note that there's a lot of existing know-how on how to do these sorts of meta-analyses, both within the HIV field, data harmonization within our large pediatric and pregnancy cohort collaborations, for example, and outside the HIV field in other drug safety work. So just to flag that there are innovations in the pipeline that may help in terms of building capacity for identifying birth defects in less resourced settings. This is an example of an app which will hopefully be able to be used as a surveillance and training tool. a kind of final word in terms of birth outcomes for women with HIV. So, of course, the safety of preconception ARVs is of critical importance, but most defects in infants born to women living with HIV are due to other causes. And some of these birth defects and other adverse pregnancy outcomes may be preventable if modifiable risk factors are addressed. So, for example, up to 11% of pregnant women with HIV in the US, Tanzania, and South Africa misuse alcohol. 43% in Ukraine smoke. 12% in the US report illicit drug use. So, of course, behaviour change is challenging, but it will have broad benefits for this woman and her children. Folate supplementation has been touched on already today, so this is something to be considering. And of course, supporting women to access antenatal care earlier in pregnancy. It's an ongoing challenge, but will have important impact in terms of pregnancy outcomes, whether it's performing syphilis screening and treatment, vaccinations for women, etc. I think it's important to note that there's global inequity in outcomes for infants with birth defects. So in resource-rich settings, there's timely diagnosis of these birth defects. For example, in Italy, in women with HIV, prenatal detection reached 65% in the most recent time period. This also gives the option of pregnancy termination. And in these settings, we have access to pediatric or even fetal surgery. In contrast, in LMICs, there's a lack of availability or accessibility of early diagnosis, and this impacts on survival of babies with defects. Limited pediatric surgical capacity contributes to the persistently high mortality that we see from treatable surgical conditions and substantial disability for those with less severe defects. And as an example, 90% of the 1.3 million children born with congenital heart disease every year don't have access to cardiac care. So I want to finish up with some quotes. I hope that you can read these, but basically they refer to the need for adequate pharmacovigilance systems, better monitoring at sentinel sites, and establishment of prospective birth registries. So these are all quotes from Nathan Ford's papers on efavirenz. And the reason for putting this up is that pharmacovigilance of ARV drugs used in the periconception period following efavirenz really stalled. And these comments still apply 5 to 9 years on, this time in relation to a different drug. So, in conclusion, increasing proportions of women are now entering pregnancy already receiving ARVs. We need to identify the safest drugs and regimens, but we have a major evidence gap, particularly for the newest drugs. We mustn't forget that a safety signal means that pharmacovigilance is working, but a balanced response is needed, as the signal may be refuted, as for efavirenz and neural tube defects. With respect to the Dolutegravir signal, more data is coming, as you're all very well aware, and it should be seen as an opportunity to grow experience and capacity in pregnancy pharmacovigilance and to prepare for responses to future signals. For teratogenicity assessment, improved post-marketing pharmacovigilance surveillance is needed so that we can get robust and timely data on new drugs. We need to ensure the sustainability of existing studies that are doing such a great job at the moment and support new studies in appropriate settings. Thank you very much for your attention.